Hello, welcome back guys. After discussing about the left ventricular pressure volume loops, now let's discuss about the jugular venous pressure changes. Okay, see, for most of the students, this topic is little tricky. They can't understand the jugular venous pressures easily. But let me make it as simple as possible for you. Okay, now first of all, look at the topic. Is the pressure changes? Okay, where the pressures are changing? In the jugular veins. So in your internal jugular vein, the pressure is changing. Why the pressure is changing and how the pressure is changing, that we will discuss now. But look at here, with one cardiac cycle, that is one systole and diastole. In one cardiac cycle, see the pressure in your internal jugular veins is increasing, decreasing, again increasing, decreasing, again increasing, decreasing. So yes, in your internal jugular vein, the pressures will increase and decrease, increase and decrease. So why such pressure changes are happening? And these pressure changes are due to, dependent on, that we will discuss now one by one. Okay. First, point number one, how many waves are there? Tell me. There is A, C, X, V, Y waves. Okay, A, C, X, V, Y waves. These are the waves. So whenever a wave is going up, it's a positive wave, which means the pressure in the internal jugular vein is increasing. Whenever a wave is coming down, it means it's a negative wave, which means the pressure is decreasing in the internal jugular vein. First, point number one, you need to understand, let's say this is your heart, sir. Okay, here is your heart. Now tell me, what is this chamber that I am highlighting? The chamber that I am highlighting is the right atria, which is receiving the deoxygenated blood from superior vena cava. Now, let's say here is the superior vena cava. The area which I am highlighting here in the green color, let's say here is the superior vena cava. So superior vena cava, it is draining into, it's draining the deoxygenated blood into right atria. Now, from where the superior vena cava is receiving the blood? The superior vena cava is receiving the blood from the jugular veins. Okay, from the head and neck region. It's the jugular veins. Okay, it's the jugular veins which is draining into superior vena cava, and the superior vena cava is draining the blood into the right atria. Now, first point is, usually in veins there are valves present. Okay, there are valves present. But here there are no such valves. Valves are absent, valveless. Okay, valveless. So there are no valves. So can I say something like this? It's the right atrium. It is into contact with the superior vena cava. Superior vena cava is in contact with the internal jugular vein. Okay. So all these are acting like one single chamber because there is no valve. There is a pressure transmission. Okay. They're all acting like a one single chamber. For easy understanding purpose, let's identify this whole thing as the internal jugular vein. Okay. Forget about the superior vena cava. Let's say, can I say something like this? Your internal jugular veins, which are there in your neck, the internal jugular veins are into direct communication with the right atrium. So you tell me, if there is increase in the pressure in the right atrium, because of some reason, if pressure increases in right atrium, what happens to the pressure in the internal jugular vein? Also increases. If the pressure in the right atrium decreases, what happens to the pressure in the internal jugular vein? Decreases. So now you tell me, the jugular venous pressure changes. The jugular venous pressures, they dependent on the right atrial pressures. So jugular venous pressures dependent on the which chamber of the heart? Right atrium. So can I say something like this? Whatever will be the right atrial pressure, it will be the same internal jugular venous pressure. So if here pressure increases, here also pressure increases. If here pressure decreases, here also pressure decreases. So from today, you should always remember the jugular venous pressures or the right atrial pressures will be same. Now instead of calling them jugular vein, can I call it as a central vein? Yeah, jugular vein is your central vein. Superior vena cava is a central vein. So jugular venous pressures or the central venous pressures or even the right atrial pressures, they are all same. So JVP is equal to CVP is equal to RAP. Okay, so from today you tell me, central venous pressures is the measurement of right atrial pressure. Jugular venous pressures, they are dependent on right atrium. Okay, so having said that, if you having this clarity, now let's go further. Step by step we will discuss now. Normal JVP. Guys, you tell me, have we discussed about the cardiac cycle? Yes, we have discussed about the cardiac cycle in the earlier videos. Now in the cardiac cycle, I have begun with which event? Atrial contraction. Okay, every time I begin with the atrial contraction. So now tell me, sir, this atria, whatever I am showing here, I am only talking about the right atria. From now, I will be only talking about the right atria because you know right atrial pressures, internal jugular venous pressure. So I am only talking about the right side of the heart. Okay, so here is the right atrium. Concentrate. Now, what is right atrium doing? You can see, sir, atrial contraction, right atrial contraction. You know, during the atrial contraction, ventricles will fill by how much percentage? 30%. Okay, right atrial contraction. You tell me, when the atria is contracting, what happened to the pressure in the atria? Increases. When the pressure in the atria increases, what happens to the pressure in the internal jugular vein? The pressure in the internal jugular vein also increases. So yes, the pressure in the internal jugular vein is increasing. That is represented as A wave. Okay. So now you tell me this A wave in the JVP. Okay, the wave which I am highlighting here in yellow color. This A wave. This is due to atrial contraction. Highlight here. A wave is due to atrial contraction. Okay, whenever your atria is contracting, especially right atria is contracting, the pressure in the internal jugular vein increases. Next, after atrial contraction, what's going to happen? Okay, atrial contraction done. After that, atrial relaxation. Now, see here I am giving the minus symbol, which means the atrial relaxation. When the atria is relaxing, what happens to the pressure in the atria? Decreases. When the atrial pressure decreases, when the right atrial pressure decreases, automatically the pressure in the internal jugular vein also decreases. So that is represented as X wave. So X for relaxation. Relaxation. Okay, relaxation. So right here, this X wave, okay, here all this X, okay, all this X, that is a phase of atrial relaxation. Okay, atria is relaxing, that's why the pressure is decreasing. Okay, so write in your book, this X wave, the pressure is decreasing. When it is seen, the X wave is due to atrial relaxation. Done. So atria contracted and atria is beginning to relax. Atria is beginning to relax. Okay. But when the atria is relaxing, who is going to begin? Ventricular contraction. The time atria is relaxing, ventricle will start to contract. Okay. So this is what we have discussed in the cardiac cycle, right? First atrial contraction, followed by isovolumetric contraction of the ventricles. Now look carefully here. The next phase is isovolumetric contraction. Who is going to contract now? Now the ventricles are going to contract. You know, when the ventricle, this right ventricle, when it is contracting, it causing the bulging of the tricuspid valve. So when the ventricle is contracting here, it is pushing, because of the pressure, it pushes the tricuspid valve into the right atrium. So into the right atrium, this tricuspid valve is being pushed. So tell me, what happened to the pressure here? Because of this, the right atrial pressure is going to increase. Now you tell me, whenever the right atrial pressure increases, internal jugular venous pressure also increases. That is represented as C wave. So now you tell me, why there is a little bump? Okay, why there is this little bump coming? So that is your C wave. Okay, let me highlight here. See, this is your C wave. That C wave is due to, tell me, C wave is due to bulging of the tricuspid valve into the right atria during isovolumetric contraction of the ventricles. Okay, here you have to write isovolumetric contraction. It's the isovolumetric contraction of the ventricles leading to the bulging of the tricuspid valve, which increases the right atrial pressure, which further increases the internal jugular venous pressure. That is represented as C wave. Okay. Now you tell me, after isovolumetric contraction, what is the next phase going to come? The next phase after isovolumetric contraction is the rapid ejection, slow ejection phases. Rep and step. During rapid ejection, slow ejection phases, the pulmonic valve is going to open. So blood is rushing into pulmonary artery. But during this time, so tell me, as the blood is going, as the blood is leaving, so now again the tricuspid valve, whatever has bulged up, now it is going to come down, come back to its place. So yes, during the rapid and slow ejection phases, there is a downward movement of the tricuspid valve. So again, right atrial pressure decreases. And at the same time, you should understand atria is still relaxing, slowly relaxing, 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 relaxing. So yes, the internal jugular venous pressure decreases. Simple. During rapid ejection, slow ejection phases, the tricuspid valve will go back to its original position. So right atrial pressure decreases, internal jugular venous pressure decreases. So this is X descent, X dash. Okay. So now write in your book, so what is this X dash representing? This X dash, it is representing, okay, this one. So here, this X dash, it is due to downward movement of tricuspid valve. That X dash is due to downward movement of tricuspid valve. But in which phase of the cardiac cycle it is happening? It is happening during rapid ejection phase and slow ejection phase. During rapid and slow ejection phases, this is happening. Okay, done. So students, tell me, atrial contraction. After that, isovolumetric contraction. After isovolumetric contraction, rapid ejection completed, slow ejection. See, again look at here. Atrial contraction, isovolumetric contraction, rapid ejection, slow ejection. After slow ejection phase, what's the next thing that's going to come? You tell me. See, after rapid ejection, slow ejection, diastole is going to begin. Protodiastole. Protodiastole is very small phase. After protodiastole, there will be isovolumetric relaxation. Yes, Next phase is isovolumetric relaxation. So during isovolumetric relaxation, have I ever taught you? So during isovolumetric relaxation, ventricle is relaxing. But what is happening in the atrium? See what is happening in the right atrium. Look, during isovolumetric relaxation, the right atria is getting filled with the, you need to understand, the right atria is getting filled with the blue color blood. What is that? Deoxygenated blood. So yes, there is a deoxygenated venous blood. Venous blood is getting filled in the atria. So it's venous filling increases the pressure. Okay, venous filling increases the right atrial pressure. So internal jugular venous pressure also increases. So now tell me, this increase in the pressure is represented as V wave. So V stands for venous filling of the right atria. Okay, seen during isovolumetric relaxation. So right. So during isovolumetric relaxation, there is V wave. What is V wave? It's a venous filling of the atria. Venous filling of the atria. Okay, done. After isovolumetric relaxation, what is the next phase? You think after protodiastole, isovolumetric relaxation, after isovolumetric relaxation, there is rapid ventricular filling. Okay, let me write here rapid ventricular filling. Rapid ventricular filling. You tell me during rapid ventricular filling what happens? See, previously all the deoxygenated blood is accumulated here. Okay, now what will happen? The tricuspid valve will open. Now once the tricuspid valve is opened, 70% of the blood will come into the ventricles. Okay, 70% ventricular filling will occur. So what is this phase? Rapid ventricular filling. 70% filling of the ventricles, rapid ventricular filling. So you tell me, whenever the blood is going down into the ventricles, what happened to the pressure here in the atria? Decreases because the blood is falling down, going to the ventricles. So right atrial pressure decreases and internal jugular venous pressure also decreases. So that is represented as Y wave. Y wave means the pressure in the internal jugular vein is decreasing due to atrial empty, EMPT, Y emptying. Atrial emptying with the opening of which valve? Tricuspid valve. 70% blood goes into the ventricles. So yes, during rapid ventricular filling, look, which wave is going to be seen? This Y wave. So Y wave. So Y wave is atrial emptying with the opening of tricuspid valve. See this V wave. V wave is due to venous filling. Venous filling of the right atria. Y wave is due to atrial emptying. Okay. So these are the different waves that are going to come with different events in the cardiac cycle, with the different phases in the cardiac cycle. The pressure in the right atrium will change. When the pressure in the right atrium changes, automatically the pressure in the internal jugular vein also changes. So the internal jugular venous pressures are dependent on the right atrial pressures. So tell me, out of all these waves, AC, X, Vy, what are the positive waves? A, C, V, they are positive waves. X and Y, they are negative waves. Okay, positive means the pressure is increasing, negative means the pressure is decreasing. Okay, what are positive and what are negative, which is important for your FMG exam. See, I can assure you 100%. Sir, you can expect one MCQ. Either in NEET PG or FMG exam, one MCQ you can expect from the topic of the jugular venous pressures. One MCQ will be pakka coming from the topic of the jugular venous pressures. Okay, doesn't matter whatever the exam is. Next, after knowing what is normal, now let's discuss about abnormal JVPs, abnormal jugular venous waveform, pressure waveforms. First, atrial fibrillation. Let's say the person is suffering with atrial fibrillation / atrial asystole. Okay, atrial asystole, which means atria is not contracting. You tell me, it's the atrial contraction. It's the atrial contraction responsible for the A wave in the monitor. See, where are you seeing all these waveforms? In the monitor. Okay, the person is lying on the bedside. There is a monitor in which you can see the JVP waveforms. Now, in a patient whose atria is not contracting, let's say atrial fibrillation, you know, during atrial fibrillation, atria is not contracting. Okay, they are just shivering like this. Okay, quivering we say. So, no atrial contraction means no waves. So, there will be absent A waves. Okay, there will be absent A waves. Next, what if the patient is suffering with the right-sided problems? That is tricuspid stenosis, pulmonic stenosis, pulmonary artery hypertension. For example, let me make a small diagram for you. This is the right side of the heart. Okay, this is the right side of the heart. This is the right atrium. Here is the right ventricle. Now, here is the pulmonary artery, let's say. Here is the patient who is having pulmonary artery. Okay. Now, here is a pulmonic valve. You know, this is the semilunar valve or pulmonic valve. Now tell me, what is the problem? Here, this tricuspid valve is getting stenosed. Okay, tricuspid valve is getting stenosed, calcified. Pulmonary valve is getting stenosed. Okay, pulmonic stenosis. Tricuspid stenosis, pulmonic stenosis. Or you can say, increase pressure here, pulmonary artery hypertension. Okay, pulmonary artery hypertension. Now in all these conditions, tell me, do you think the blood can go to the lungs easily? No, here is a block, speed breaker. Here is a block, speed breaker. Here is a one more block, speed breaker. Pulmonary artery hypertension. See, here already there is more pressure. Now I am asking you, tell me, the blood will go from high pressure to low pressure. This is normal. High to low pressure, normal. But already here, see, there is higher pressure present, pulmonary artery hypertension. Now, do you think easily blood can come to the area wherever there is hypertension? No, cannot. So in all these conditions, tell me one thing. Is it easy for the blood to go to lungs easily? Is it easy for the blood to go forward? No, definitely not. So what will happen? Sir, atrial hypertrophy. In order to push the blood forward, the atria is becoming hypertrophied. Even the ventricle also, of course, ventricle will also undergo hypertrophy. Atria is also undergoing hypertrophy. Right side of the heart is undergoing hypertrophy. So you tell me, now is it a big atria or small atria? It's definitely a big atria, sir. Big atria, when it contracts, it generates more pressure or less pressure? Definitely, without any doubt, it is going to generate a higher pressure. High right atrial pressure. So now tell me, during atrial contraction, more pressure is generated in the right atria. So the internal jugular venous pressure is also going to be very high. So what will happen to the A waves? Large A waves are going to come. Okay, now the A wave is going to be large. So in these three conditions, like tricuspid stenosis, pulmonic stenosis, pulmonary artery hypertension, there will be large A waves. Okay, large A waves are going to be seen. Done. Next, after this, look at the next condition. The next condition that I am going to discuss here is AV dissociation. What does it mean by AV dissociation? What is the full form of AV dissociation? AV dissociation means atrioventricular dissociation. Okay? Atrioventricular dissociation. What does it mean by atrioventricular dissociation? Guys, let me tell you something. Usually how the heart will contract, first atria will contract, the blood will go into the ventricle. Later ventricle will contract. First atrial contraction, later ventricular contraction. Atrial contraction, ventricular contraction. Okay, but what if both atria and ventricle is contracting at the same time with a closed tricuspid valve? Okay, because ventricle is contracting, no, so tricuspid valve will be closed. So both atria and ventricle are contracting with a closed tricuspid valve. So there is no coordination between them. Okay, there is no coordination. Both the entire heart is contracting at the same time. So this is called as atrioventricular dissociation. Okay, both, let me write here, both atria and ventricle, both atria and ventricles contracting at same time. Okay, both the atria and ventricles are contracting at the same time. Or they can say it the same thing in a different way. That is atria contracting against closed tricuspid valve. Atria is contracting against a closed tricuspid valve. You tell me, when atria will contract against a closed tricuspid valve, at the same time ventricle is also contracting. That means both atria and ventricle is contracting at the same time. This is called as atrioventricular dissociation. Such atrioventricular dissociation is going to be seen in three conditions. That is complete heart block, junctional tachycardia, ventricular tachycardia. So in these three conditions called as a junctional tachycardia, ventricular tachycardia, the atria ventricular are going to be dissociated. They are not coordinated. So you tell me, when an atria is contracting against the closed tricuspid valve, what will happen to the pressure in the atria? Increases tremendously. The pressure in the atria increases so much. So there will be super large A waves. There will be very, very big A waves. They are called as cannon A waves. Okay, now they are called as cannon A waves or giant A waves. Cannon / giant A waves. Okay, so these are the three A wave abnormalities which I want you to know for your exams. Okay, NEET PG, FMG exams. These are the three things which I want you to know. Absent A waves are seen in atrial fibrillation. Large A waves are going to be seen in tricuspid stenosis, pulmonic stenosis, pulmonary artery hypertension, etc. And cannon or giant A waves are seen with the atrioventricular dissociation, and atrioventricular dissociation is seen in three conditions: complete heart block, junctional tachycardia, and VTAC, ventricular tachycardia. Okay, done. Now, if a patient is suffering with a tricuspid regurgitation, let's say The person is suffering with what? Tricuspid regurgitation. See, how I used to remember when I was a student is a tricuspid regurgitation starts with the letter tri. So, tricuspid regurgitation, 3 JVP changes are going to be seen. 3 JVP changes. Okay, 3 JVP changes. What are the 3 JVP changes going to be seen? Absent X descent. One change is absent X descent. Next, prominent Y descent. Okay, and tall V waves. They are also called as a CV waves. Okay, CV waves seen in tricuspid regurgitation. So, what are the 3 JVP changes that are going to be associated with that is going to be seen in the tricuspid regurgitation? Absent X descent, prominent Y waves, and tall V waves. Now, for your better understanding, let me show you. This is how a normal JVP pattern. Sir, A wave, C wave, X, V wave, and Y. A, C, X descent, V wave, and Y wave. This is normal. Now, what happens to this JVP in a patient with a tricuspid regurgitation? Look carefully. In a patient with a tricuspid regurgitation, okay, A wave normal, C wave also okay, but who is not there? X descent is absent. So, there is no X descent, okay. After C wave, there is tall V wave, directly tall V wave, and sharp, prominent means sharp Y wave is going to come. Okay, this is how the JVP is going to be there. Okay, so there is no absent, or I should say there is no X descent, So this X descent is absent. So immediately followed by A, there is C, immediately following C, which wave is coming? V. There is no X descent. So that's why it is called as a C followed by V. So CV waves, we call them as a CV waves. And there is a prominent Y descent. Okay, prominent Y descent. So this is how the JVP is going to be changing. See, let me tell you. See why I should know all these abnormalities. Okay. See, have you ever heard something like this? A good doctor always diagnoses the patients. Okay, good doctor always diagnoses the patients with minimal tests. Okay, with minimal tests. You should not order all high-end tests, hi-fi tests. Okay, with small things you should put the diagnosis. Okay, see, usually people used to say just by the way the patient walks into your clinic, you have to put the diagnosis. Okay, have you ever heard about it? In the same way, see, listen guys, the person is just having some problem, he is lying on the bed. Now, everything was seen in the monitor. You can see, you can absorb all these JVP pressures. Okay, you can see the jugular venous pressure changes in the monitor. Okay, so imagine if I am the doctor. Okay, if I am the doctor and well experienced doctor, good doctor, what I am going to do? I am going to first look at the monitor. I will see A waves are absent, A waves are not coming, which means the patient is going into atrial fibrillation. Okay. So just simply, if I feel like, so the A waves are not coming, so the patient is developing a sustained arrhythmia called as atrial fibrillation. Okay. If I see in the monitor, I cannot see the X descent. There is no X descent. C wave immediately followed by the V wave, and there is a sharp Y wave. Okay, sharp Y wave. If I am seeing this pattern on the monitor, okay, X descent is absent. There is a tall V wave and sharp Y wave. Prominent Y means sharp Y. Okay, the patient is having tricuspid regurgitation. Maybe the person is suffering with a tricuspid regurgitation. Even with small things, you can identify what is the problem inside the heart. Of course, we will send the person to the ultrasonography. In ultrasound, if there is tricuspid regurgitation, we can find it. That's the one way. But even by looking at the jugular venous pressure changes, you can actually know what is something wrong with the heart. Okay, that's the concept. Next, constrictive pericarditis. So this is very simple. In a patient with constrictive, see, I am not going to explain everything about constrictive pericarditis. Simple. Integration, normal JVP and abnormal JVP waveforms. In a patient who is suffering with constrictive pericarditis. Constrictive pericarditis means what? Calcified pericardium. Calcified pericardium. Okay, the pericardium is totally calcified. Okay, maybe because of some infection, maybe TB pericarditis, some reason, pericardium is calcified. In this person, constrictive pericarditis, everything will be prominent. Prominent X, prominent Y. So, prominent X descent, prominent Y descent. Okay, prominent X, prominent Y. Prominent means sharp. So, both prominent X and prominent Y. Okay, prominent X and prominent Y. Done. Next, what if the patient is suffering with a cardiac tamponade? You know, Cardiac tamponade means the fluid accumulation around the heart, compressing the heart chambers. Okay, sudden accumulation of the fluid or blood or anything which is going to cause the compression of the cardiac chambers. So that is called the cardiac tamponade. In a patient with cardiac tamponade, which JVP changes will be seen? Okay, which JVP changes will be seen? The JVP changes are prominent X, absent Y. Okay, prominent X and absent Y. So Y descent is going to be absent and the X descent is going to be prominent. So these are the abnormal JVPs. Again, recap. In a patient with atrial fibrillation, absent A waves. In a patient with tricuspid stenosis, pulmonic stenosis, pulmonary artery hypertension, there will be large A waves. In a patient with atrioventricular dissociation, there will be cannon or giant A waves will be seen. In a patient with a tricuspid regurgitation, 3 JVP changes are going to be seen: absent X, prominent Y, and tall V waves called as the CV waves. In a patient with a constrictive pericarditis, both prominent X, prominent Y. In a patient with a cardiac tamponade, prominent X, absent Y. So this is a recent question which was asked in the exam. Absent Y descent is seen in going to be seen in the cardiac tamponade patients. Okay, done. Now after this, what else I should teach you regarding the jugular venous pressure changes? My dear students, let me ask you one thing. Whenever you do inspiration, look at me. What am I doing? I am doing the inspiration, no? Whenever I am doing inspiration, there is a negative intrathoracic pressure developed here. Okay, there is a negative intrathoracic pressure. This negative intrathoracic pressure, it is going to pull the blood from the parts of the body. It is going to pull the blood from the internal jugular vein into the superior vena cava and towards the thorax. The blood is being pulled towards the thorax. So you tell me, the blood is not accumulating in the internal jugular vein. It is being forcefully pulled down. So blood is not accumulating here. If the more blood accumulates, more pressure. If the blood is not accumulating here, the pressure will decrease. So always remember, in a person, in a healthy individual, whenever you do inspiration, the jugular venous pressure will actually decrease. It should decrease. Okay, but what if it is not decreasing? If it increases, if it is not decreasing or if it increases, then it is called as a Kussmaul sign. So let me explain you what exactly is a Kussmaul sign. Okay, what exactly is a Kussmaul sign? Guys, look at here. What is normal during inspiration? Normal is jugular venous pressure should decrease. What if JVP increases on inspiration? What if your JVP is increasing? This is called as, so during inspiration, if your JVP increases, then it is called as Kussmaul sign. Okay, then it is called as KS, Kussmaul sign. Okay, now just look at the definition here. Typically means normally. Typically, JVP will decrease on inspiration. Okay, because the negative intrathoracic pressure, it sucks the blood from the vena cava towards the thorax. Whenever there is a lack of decrease or increase in JVP, whenever there is a lack of decrease or increase of JVP during inspiration, this is called as a Kussmaul sign. So Kussmaul sign is increase in JVP during inspiration. Very important. And they will ask you, such Kussmaul sign is seen in. So such Kussmaul sign is seen in, the mnemonic which I gave for myself is KCR. Okay, KCR. So Kussmaul sign, K for Kussmaul sign. Okay, Kussmaul sign, it is seen in 2 conditions. Okay, what are the, actually in 3 conditions? What are these conditions? C for Kussmaul sign is seen in constrictive pericarditis and restrictive cardiomyopathy and right heart failure. There are 2 R's. C for constrictive pericarditis, R for restrictive cardiomyopathy and right heart failure. So right here, Kussmaul sign is associated with a seen with KCR. Okay, KCR, KCR. So C for constrictive pericarditis, R for restrictive cardiomyopathy or right heart failure. Okay, no? So that's it. So these are the different conditions in which you can expect a Kussmaul sign. So with this, we have completed all the important points about the jugular venous pressures. I have told you how the jugular venous pressures are going to change with the cardiac cycle. Okay, A wave is because of, C wave is because of, X wave is because of, Y wave is because of. Out of all this, for your FMG exam and NEET PG exam, the two important waves which are important, A wave and C wave. A wave is due to atrial contraction, C wave is due to isovolumetric contraction leading to the bulging of the tricuspid valve into right atrium. These two A and C are very, very important. Next, after that, in abnormal, always they will ask absent A waves are seen in atrial fibrillation. Absent Y is seen in cardiac tamponade. Cardiac tamponade, absent Y. Okay, so these two are very, very important. So with this, we have completed the whole JVP. I hope the video is helpful. Thank you.